One interesting presentation at ASCO was by Dr. Arbour and colleagues from Memorial Sloan Kettering, looking at the results from their institution along with those from Institut Gustave Roussy in France, and specifically questioning whether the patients who are on a moderate to high dose of daily steroids, 10 milligrams of prednisone or higher on average, who were also on immune therapy for advanced lung cancer, had any different outcomes. And they saw in their retrospective look back at the data that the patients who were on daily steroids had a lower response rate, a shorter time before the cancer progressed on average, and a shorter survival. And I think we're appropriately questioning, is this because of the steroids, or is it because of whatever reason they had to need steroids? But we're seeing some new data all the time. There was actually a brief communication in one of the journals that just came out today, I believe, that's looking at the Cleveland Clinic experience that suggests that Opdivo was not as effective in patients who were on steroids in the first month on treatment. So, well, Sandip, what do you think of this?
Well, I think for patients it's important to know we're not talking about the steroids you get with chemotherapy.
Right, not the short burst.
Yeah, not the short burst. And we're not talking about if you have a contrast allergy, getting a day of steroid. We're talking about patients who are getting greater than 10 milligram of prednisone for months and months and months.
Right.
And so these are patients with either autoimmune conditions or bone metastases that have a lot of inflammation. And depending on which series we're talking about, whether it's Cleveland Clinic or the Memorial Group, I view this as, is this just showing us that patients who have a lot of risk factors aren't going to do as well on immunotherapy, but they could still benefit. And so I wonder if it really just relates to the reason the patients are on the steroids in and of themselves is the reason they're not getting the benefit. Now, is there a chance that the steroids can blunt the benefits of immunotherapy? That's what really everyone's truly asking, not that if a patient happens to be on steroids, what happens next? And if we look at the data, at least from melanoma, where they get a lot of side effects, if you have an autoimmune side effect on immunotherapy and you get steroids, there's no change in overall survival or how fast your cancer grows. And so I do want to emphasize that we hear a lot about how steroids may have a negative interaction with immunotherapy, but if you're getting the steroids as part of your chemotherapy, or you get an immune-related adverse event because of the immunotherapy, you have no decrement, no loss in your survival.
I think of that a little differently. I mean, the reason is that for patients who have a really robust side effect issue and need to start steroids, that's not that different from our experience with when we give EGFR inhibitors and patients get a bad rash. You can lower the dose and these patients do very well. It may be that the patients who have the most robust side effects are the ones who are having the most robust immune response, and you're just pruning that back from the danger zone, the red zone, and that's different from wet blanket to really dampen the immune system. I'm concerned that when you see survival, that could be from brain metastases or the various complications. It's not as clear to me that the effect or the association of being on chronic steroids with lower response rates and progression-free survival, that seems to be more of a direct association.
And to me, that's the most provocative data. That's from the Cleveland Clinic series. And so I think the idea, it's kind of like the antibiotic story with immunotherapy as well. We want to have patients on the lowest, most judicious doses.
Right. I think that this data certainly is provocative in the fact that what's happening to a person's body, not only their immune system, but also their gut. There are other things that are going on here that I think that we don't understand the host's role when you have chronic steroids being on board. I believe that probably your gut is also changing its makeup, and we know how important the gut is in the contributing to having an immune response. Also, we know there are other things that we know. We know that weight and body mass index plays a role in the host immune response as well. So I think what it tells me is that there's something that is happening that's putting the brakes on the immune system, but there's probably going to be other things involved here as well. So that's my take-home message from it. It's certainly very fascinating, I would say, and again, to the antibiotic story, to where we now really are trying not to have people be on antibiotics.
And just to clarify, because we're talking around that, there's some suggestive evidence that patients who are on antibiotics may not do as well.
Yeah.
Right.
Exactly. And we need to learn more about this. We need to learn more about the steroids, but cautionary, and just suggest we should be judicious.
But it's all related. I
Yeah.
think, again, it's all related to the host immune ability to respond.
Mm-hmm.
And we're putting the brakes on it, whether it's with an antibiotic, whether it's with a steroid, whether it's with someone's own body mass index, that's contributing in a negative way, that if we could understand all of this better, we could be able then to try to work around some of these issues.
And so my take-home points as a provider and to patients is that if you're on high-dose steroids, if there's the ability to get off steroids, that's a worthy goal anyway, because steroids have side effects in and of itself beyond of what we're trying to accomplish with immunotherapy. And that for a patient who requires high-dose steroids, these may be the patients that even if their PD-L1 is greater than 50%, I may actually favor a chemotherapy plus Keytruda approach. Because if I'm worried about the immunotherapy not being as effective, at least I have the chemotherapy as a buffer for that. And so I think it influences in terms of personalized medicine how we treat the patient and match their pre-existing conditions. But I think one thing I don't want to take away, because if you look at a lot of the headlines, it makes steroids sound very scary, is that if you need steroids for an autoimmune side effect or you need it for the chemotherapy, very different question than what we're talking about here.
Right.